Good morning, everybody. Today I will be talking about the mental and emotional health of in adults born prematurely. So here you see Nigel. Supposedly he's relaxing in Jamaica, but you can see he's ready to sprint at any moment to do something else. And can this man really retire? I have my doubts. I'm sure that we'll be hearing new and innovative ideas from him pretty soon. So again, I feel privileged to be invited with this audience of all his colleagues and friends. So thank you very much. But Nigel's brilliant career aside, I would like to pay tribute to Nigel. And as Dr. Misra said, loyalty. And I really admire Nigel for his humanity, his mentorship, his friendship, and his warmth. And he has been really amazing. And most of all, I admire him for his Jewish jokes, which we hope to hear at dinner time. No one can match his delivery. So in the 1990s, I know Nigel for a very long time. Nigel had the idea of looking at how treatment decisions influence the outcome. And for that, he gathered a group of people who had epidemiological data on the behavior and mental health of and cognition of these children who were very low birth weight or less than 1,000 grams. And so we had a team from Netherlands, Germany, Canada, and the US. And as you can see here, that there were similarities in the trends, but the differences were mainly statistically significant in the European countries. Now, this is the first time that cross-country comparisons was made in very low birth weight infants. And it's been a remarkable achievement of Nigel. And we also had differences in cognition. So Nigel has been influential in my career as well, in collaborating with people internationally, which we have done. And Nigel has also been part of our adult studies on premature infants, and I'm very grateful for that. So today I will talk about the mental health, socialization, and psychiatric outcomes in very low birth weight and very preterm infants from the McMaster studies and our collaboration, APIC collaboration, which I will comment on soon. And I would like to highlight the methodological problems in the current studies and to demonstrate the advantages of individual participation data analyses, and finally, the implications of the above findings. So we know for several decades that premature children have mental health and behavioral problems, but we've all been doing cohort studies, and the cohort study sample size is very limited, so it has low statistical power. And we have been asking about behavior from parents, teachers, and the children, but it's not diagnostic. It's helpful, but not diagnostic. And the Scandinavian studies have been amazing because they have data from birth to death in very large cohorts, and it's been very helpful. But again, this data is not strictly research oriented, and so there's been underreporting and diagnostic inconsistency. And because of the small sample size, people have been doing meta-analyses to get a larger sample. So here, it's a busy slide, but just to tell you, Scandinavian, Swedish, and McMaster studies, we had similar kind of findings that there was increased risk of psychiatric disorders, ASD, and ADHD. And the Swedish study also showed increased hospitalization and increased use of antidepressants and hypnotics. And the McMaster study, again, it was self-reported, and we had 142 ELBW, and we followed 86% of those and 92% of the normal birth weight, with self-reported, the assessments, and they reported depression, anxiety, avoidant personality. And there were no differences in externalizing symptoms, which is consistent with all the studies. So as you can see, it's a small sample, but it was a population-based sample. And at 29 to 36 years of age, again, this time we did structured psychiatric diagnostic criteria interviews of these children. And again, you see the same disorders appear: depressive anxiety, social phobia, panic disorders, ADHD. And again, another consistent finding in every single study is that they are risk averse and use less alcohol, substance abuse, and less incarceration and contact with the police. So if you take any substance psychiatric disorder, the OR was 2.5, and it's statistically significant. Now, at the bottom of the slide, you'll note that we lost a lot of patients, participants, so the sample size gets smaller. And people always say premature children are different, what's different about them? So they're shy and they have behavioral inhibition, they're risk averse, as I mentioned, they're less sociable and less extrovert, less assertive, less outgoing, and also less likely to seek new experiences. So, they're supposed to be really good kids, dutiful, cautious, timid, shy, withdrawn, and agreeable, and less promiscuity, less risk-taking behaviors. So this adult-born preterm international collaboration I was working with the Finns. We had a collaborative grant. For some reason, it was a Canada-Finland proposal, and we were successful. And I was sitting with the Finns in Helsinki, and I said, if I can work with you, why can't I work with the rest of the world? So Eero Kahanti, who was my co-founder, said, oh, that's a good idea. So I wrote to everybody, and amazingly, everybody replied, happy to share data, happy to brainstorm. And I am just so overwhelmed by the results of this collaboration, because we were meeting, it's non-funded, we were meeting post-PAS and post-ESPR, and we reported on the blood pressure, mental health, respiratory outcomes, and also recommendations for future studies in adulthood. And we started with 12 people, and now we have 125 members, and Michael O'Shea is also part of that. And it's very successful. People are very enthusiastic. So I will present two studies from the APIC participation on the mental health. And so this is all very low birth weight and normal birth weight from the APIC study. The first study was IPD analysis of the diagnostic criteria for ADHD, ASD, anxiety and mood disorders. And we wanted to see if there were differences between the premature and the normal birth weight, and also by sex and age. The second one was performed using Alkenbach self-report. And again, this is a large sample from the APIC studies, from about 8 countries and 10 cohorts. So I'm preaching to the converted. In fact, I learned a lot from this myself, that the traditional meta-analysis provides aggregate data based on a whole body of research, whereas individual participant data relates to raw individual data recorded for each participant. So naturally, this has clinical and statistical significance. So individual participant data meta-analysis can model the individual risk across patients, and in contrast, aggregate meta-analysis can only model the proportion of high-risk patients across the studies. So the results of the first study, which is the structured psychiatric interviews, and you can see it's amazing that we have 1,385, nearly 1,400 very low birth weight who had structured psychiatric interviews, and nearly 1,800 normal birth weight. And so what we found was that there were 10 times higher odds for ASD, which was higher with decreasing gestational age and in males. 5 times odds of ADHD, 3 times more anxiety or depression, and mood disorders also. So this study provides support for the preterm behavioral phenotype, which is associated with inattention, anxiety, and social difficulties. The second study is the self-report by Achenbach adult self-report, and the results showed the similar findings that we presented earlier: more internalizing, more avoidant, less externalizing, less rule-breaking and intrusive, and less antisocial behavior. And so we included all the children. I keep calling them children, they're adults. We included all the adults, and then sensitivity analysis with excluding participants with neurosensory impairments, which did not alter the findings substantially, nor did IUGR. So in summary, these two studies are unique by the inclusion of a large international cohort of very preterm participants and novel birth weight peers, and using psychiatric diagnosis with structured measures and self-reported mental health problems. So the pool data, as you saw, from 60 to 100 cases in cohort studies was now more into 1,400 or so. And these data were collected from 5 to 8 countries, which provides a broader cultural perspective. So this is also the first time that individual participant data was used in the analyses, and it has obvious advantages. And these studies reveal that individuals born very preterm have higher odds of meeting psychiatric disorders through childhood and into adulthood, and I fear it may progress further. So as determined by self-report, they have heightened risk of internalizing problems, but not externalizing. So the implications for future is that we have to accept they're different and they have more psychiatric problems, and it's likely due to structured abnormalities of the brain. And this peer victimization, which goes on a lot in even normal birth weight, but in preterm, it's very significant. And we've shown it's associated with adverse psychiatric outcomes. And these mental health issues and personality differences might explain, some premature children are doing just as well as the controls, but they're not employed and they have less romantic relationships. And this personality might explain some of the differences. So in future, we know that early vulnerability factors have long-term consequences, and we should really look at children at the younger age and provide supportive measures. And most importantly, when we transfer our children to internists, they should be aware that they should look at the birth history, because there's so many things that are preventable. Look at blood pressure, look at behavioral problems. And research into preventative intervention is really warranted. And we should follow these children to middle age. We'll probably have to get newer investigators, as these children will outgrow the current investigators who are no longer going to be around. And future research should include newer cohorts, because therapies have changed so much. So again, I owe immense gratitude to my children who have been following me around for several decades. And this work would not have been possible without the assistance of my many mentors, McMaster collaborators, research staff, and the generous funding from NIH and SCIHR. Thank you very much.